Introduce the next presenters, who are Penelope McMillan, the speak person and director at MECFS Australia, as well as Dr. Maria Alejandra Pinero de Plaza, who's a research fellow at Caring Futures Institute in Flinders University. And the topic of the presentation is going to be about research into frail and homebound, as well as bedridden people, and collecting their experiences to develop advocacy tools. So the presentation will be shared by Dr. Maria as well as Penelope. Thank you.
Can you see it?
We are.
Okay, so I will move the slides and Penelope will begin our presentation.
Yeah. So with our research into frail, homebound and bedridden people, the project is not just research, but also innovation. So we're interested in collecting experiences and developing advocacy tools that's very purpose-driven. So thank you to AME Group Australia. We acknowledge the traditional owners and custodians of the land from which we're presenting today, which is the Kaurna people, and pay our respects to their elders past, present, and their emerging leaders. And we also acknowledge the traditional owners and custodians across Australia, wherever people are watching today, and also extend our respect to Aboriginal and Torres Strait Islander peoples who might be with us today. Because Alejandra's, she's put a really nice diagram here of health system enablers and barriers to continuity of care for First Nations peoples living with chronic disease, because often, those of us who perhaps have greater personal privilege, well, we think we've got it tough, and then you go to intersectionality and things get even tougher. So there's a QR code there and a link if you're interested. Thanks. So we're going to talk about the origins of the project, what the community need was that began the project, look at the academic need, key outputs and outcomes. And I mention Medicare and telehealth, which has already come up this evening, and look at new evidence and advocacy tools that have been developed. So from the community point of view, all of this started with Ricky Buchanan, who authored a report called Just Invisible: Medical Access Issues for Homebound and Bedridden Persons. So there's invisibility, there's marginalisation, there's deterioration of health and quality of life. And there are barriers to accessing disability welfare and other supports. If you are invisible to the health system, you can't get the medical reports you need to access the disability sector, the welfare sector, and special housing, anything. It's you just you're invisible to the government and to its services, as well as to your local community. So around 600,000 Australians aged over the age of 5 can't leave home as often as they would like due to their disability or condition. And the majority of those people are under 64. People often think frail, homebound and bedridden means elderly people. A significant portion of these people have severe ME. We are a large group within the frail, homebound and bedridden people. I'd been showing Ricky's report to anybody who I thought ought to know about it or might do something about it. And Alejandra and I know each other through advocacy in the health sector. So here we are in that photograph there with a group of people at the South Australian Health and Medical Research Institute involved in consumer and community engagement in health and medical research. And once I showed the report to Alejandra, she took it back to her job at Flinders University. And then the Caring Futures Institute at Flinders decided to give us our seed funding, and we were away. So the academic need, we started with a video evaluation on frailty that wasn't specifically about people who are homebound. And that actually triggered something because from the MECFS point of view, a few of us had a look at these frailty videos and go, not right for us. And so then we start looking at knowledge translation research what is the knowledge and how do you translate it through research into change? And yeah, our previous experience as consumer advocates and our interest in engaging with stakeholders, co-researchers, is an absolute feature of everything we've done. So some of the early outputs included, going from the left, I did a survey of people who considered themselves to be frail, homebound, or bedridden, developed a video that was designed to assist people who had never ever considered that there were unseen people in their community to actually go, oh, all right, and at least raise awareness that these people exist. And then one of our early outputs was there's a video-based health journal in Australia, and we presented together. But we also, gosh, posters at conferences, presentations at conferences, lectures, um, setting up a Facebook page. Yeah, we go on the radio and we write to journalists and all of that. With the survey, one of the things people were asked to do were to take photographs, if they chose to, of their hand touching something that's important. So if you look at these things that are important to me, there's a couple of themes here. Again, from the left, you're looking at a telephone or a keyboard, ways of communicating from your bed, which is what I'm doing tonight. I'm in bed, to the wider world, the natural world, plants and gardening, flowers, pets. They're not all dogs and cats. There's birds and rabbits and every other sort, and relationships with other people. Then some people chose to photograph things that they've lost. So the really obvious one is things like running and swimming and other physical activities. Also careers. Those who were fortunate enough to have a career before they got sick, um, generally that's just gone. That's a massive loss. And also hobbies. So in this instance, someone's reaching for their guitar that they can no longer enjoy playing. What do these households look like? So one question was, do you live alone? So 2/3 of them don't. They've got someone else in their household, but about a third of frail, homebound, and bedridden people live alone. And if you imagine having no access to the health system, to government agency support, and um, living alone, so you've got no one to help you. We're talking about an enormous number of people living in quite dire circumstances. Marital status, most of them were single, or the largest group was single. Then there were about a quarter of them were married, and a significant group of divorced people. Um, some people have children living with them, but 78% not. So that's, 4 out of 5 people don't have children with them, but some of them are responsible for young children. In the last year, have you experienced, there's a whole heap of tick boxes, and some of the big ones were social isolation, 88%. A reduction in capacity to participate in family and community life, 87%. We have a lived experience video in South Australia where a 22-year-old who, for his 21st birthday, his grandmother came over for afternoon tea, that was it, and he joined the family for 6 minutes. So that's the level of loss, even when you're living with a family. And then a reduction in overall health, 85%, most of them, of course, report that. In terms of diagnoses and being bedridden, how many chronic conditions do you have? And a lot of them have 3 or more chronic conditions. Some have 2 or more, and a small number have just the one chronic condition. Have you been diagnosed with any of these particular conditions? ME/CFS was a big one. And then fibromyalgia in terms of chronic conditions was the second largest group. Do you need to stay in bed most or all of the time? So more than half of the people who identify as frail or homebound do stay in bed most of the time. And the rest of them don't need to. But that's a lot of people who are bedridden. So ask people about their needs, of course. So many don't have any support to clinical services. Often they don't have a regular primary care provider, such as a GP, because the Australian health system is designed around patients' physical attendance. And when you ask people, what's the thing you really, really want to see happen? Nearly everyone wanted education for health professionals and service providers about their needs. Nearly everyone wanted to educate Centrelink, the NDIS, government services about just how hard it is to manage the paperwork and their processes. People, 9 out of 10 want access to community care services such as the NDIS or aged care packages. In other words, they're not getting them, 90% not getting that support. People want adequate Medicare rebates for home visits. Why can't a GP once a year drop in to say hello and then you can have access to telehealth? And people want the telehealth that's available to rural and remote patients to also cover patients who are isolated at home, who are housebound or bedbound. So Australia has Medicare subsidised telehealth. So what's the problem? Well, the problem is that to be eligible for that, you have to have had a face-to-face consultation with your GP in the 12 months before the telehealth service. Right? And there are exceptions, and they're listed on the bottom right, like experiencing homelessness or being under 12 months of age, being in a natural disaster, needing mental health support, but being homebound, nope. That's not on the exemption list. People told us, oh, My Medicare is coming in, and if you register with My Medicare, then you're eligible for telehealth. You don't need to do the face-to-face eligibility. But then when you look at My Medicare, you can't register for My Medicare unless you've seen your GP physically twice in the previous 2 years.
Thank you very much, Penelope, for this presentation. So Penelope talked about a survey that we did in during COVID, in fact. But we designed it previous to COVID. And the information that she reported included quantitative data that people tick boxes and also qualitative data where people told us about their stories. And we also collected the pictures that she showed. Those are pictures from the homebound people. And in total, we collected 300 responses. And based on that work, and many co-design and consultation with many groups that Penelope has contact with because of her extended networks of consumers, we thought, well, we know. We have been discussing this, Ricky Buchanan have been discussing this, the difficulties and the experiences, the harrowing experiences the homebound people are having. And how can we demonstrate this for policymakers? How can we, what do we need to create so that they hear the important needs of these populations? So we, in 2021, we published, no, in 2023, excuse me, we published a protocol about the need of investigating telehealth as a solution, because in 2021, we published a book chapter indicating that the people during the COVID-19 pandemic, homebound people fared much better because they, for the first time, had access to telehealth services without the need to a physical consultation. So based on that body of work and research, we thought, well, this is what we need. We need to demonstrate that, in fact, telehealth work, because if you read the press, and if you watch TV, what you hear from practitioners is that sometimes the telehealth doesn't work, the evidence is not there, we don't know, we don't have the opportunity to assess people in person, etc. So we thought, how much of this is a reality? And that's where we developed this systematic review. The question, the general question will be like, is telehealth as effective as a care solution for homebound people compared to in-person care? So what we did is that we investigated the homebound individuals with severe health social conditions that wouldn't allow them to leave their home. And in the review of the literature that we captured 2,245 patients. The interventions that we considered for this review were when they were where the consultation or the service of the care was done through video, phone, digital platforms, assistive technology, sensors, etc. The comparison was in-person care. And the outcomes that we were looking for was healthcare utilization, health-related quality of life, and well-being. So what did we do? We collected data from several data searches for Medlines, NBASE, SiteInfo, CNIL, Cochrane Central, Scopus, Liliac, Web of Science. We collected data from all times until August 2023, all papers. We screened 3,289 papers with these characteristics that I just mentioned. From that, our team selected 10 studies that were meeting the PICO description that I gave you, and 8 studies were suitable for meta-analysis. Why do we need a meta-analysis? Because we needed to demonstrate, bring evidence, significant evidence, quantifiable, because the problem is that we had a lot of experiential stories, but we always felt like, oh, there is not rigorous evidence. And that's why the systematic review was only including data from RCTs, which is randomized controlled trials, which is considered the gold standard for evidence, and quasi-experimental studies. So those studies were the only ones that we included. And these studies included treatment from 3 months to almost 2 years, so that they were comparing telehealth versus standard care. This process was co-designed with 21 co-authors, including homebound people like Penelope and other people and her networks, and many healthcare practitioners of different disciplines and researchers and academics. So what we found, this was published just a month ago, and this is what we found. In terms of healthcare utilization, actually there is a reduction of healthcare utilization when we have telehealth. What does it mean? It means less visits to hospitals, less utilization of services, because we are supplementing support, through virtual care. In terms of health-related quality of life, we found a significant increment in the quality of life of those receiving services through telehealth. In terms of well-being, we got a significant increment into the well-being of those who receive telehealth compared to usual care. So in terms of the meaning of this reporting, so we use standardized means to compare across results. And when we said in terms of evidence, low certainty, moderate certainty, these are technicalities that are important for researchers. We use a great tool. Is called a tool to assess the certainty of the evidence. But look, when we assign low certainty, moderate certainty, it has to do more with the kind of data that we collect. Because we excluded gray literature, meaning things that are published outside the academic, etc., that actually gives some bias to our study, to only the information that is published. And that's why you see this certainty of evidence rated differently in the study. The truth is, and what we found and demonstrated here, is that in fact telehealth can be applied as a healthcare solution for homebound people. And another interesting part of this systematic review is that, as you heard from my previous slide, we consider homebound to anyone that was at home for more than 6 months, and couldn't leave because of chronic conditions, because of limited mobility in terms in any kind of definition. So why this is important? Because when you try to find systematic reviews or RCTs, you will find information or evidence for a specific group, a specific diseases, a specific. So what's the problem with that is that we don't have enough numbers to demonstrate why this is helpful. So when we group everybody that is homebound, at least we have a mass of people that we could say to policymakers, look, this is a significant group, because many homebound people live there, are homebound because of rare diseases. And when I say rare diseases, it's not my definition, it's the definition that is given to diseases that there isn't enough research about it. So people say, oh, this is not really, because it's not really relevant because the population is so small. Well, that's not the case. We are aggregating. That's why we talk about frail, homebound, and bedridden people, and that include all sorts of population. And this study is the first one that integrate those in this way. So in the beginning of the presentation, we talk about advocacy tools. So as Penelope mentioned, we identified these harrowing needs, and we decided to produce material that could serve to anyone that is ready to advocate for homebound people and the utilization of telehealth. So as you can see from right to left, there we have the published protocol for the systematic review that I mentioned. And this is a Q1 journal. It was published there, and everyone understand now the need. It is published and peer review. Then we also, in several conferences and book chapters like we did, we published, like with the survey data that Penelope talked about, we use different types of epidemiological manipulations. Why? Just to demonstrate that we can use this data in different ways to present the important needs of these groups and demonstrate how different methodologies can help us do that. So the example is this book chapter that you got in the middle, where we pilot a big data epidemiological approach to understand the needs using the survey data, qualitative and quantitative. And then, of course, the systematic review again. And this is the final publication, is open access. So no one has to pay to access this information. You can download it, send it to your MP, say why this is important. So this is evidence that you can use for submissions to the parliament, submissions to anyone that you want. You have now scientific evidence that support the utilization of telehealth for your care. So in the same, like I said, we produce a lot of stuff. One of the most significant outputs that we have produced was an digital socio-scientific exhibition. So online, we created, if you go through that link or to use the QR code, you will get access to a socio-scientific exhibition of the problems that we found through the survey, the experiences of the homebound people. You will find around 20 posters that you can download, print, submit them to your MP. You can print them and share them with your local community, exhibit them in your local library. Those posters have links to different studies where we demonstrate what we're saying here, the need to address the needs the homebound people have, and their experiences as human beings and persons that need to be incorporated, and their solutions as well. So in this exhibition, you have videos, you have posters, and you can share that. All is free, all is downloadable. And to the here at your left, you will find the first book chapter that we did during COVID. At that time, no, now it's not there anymore, but it's a book chapter online that you can download, published by iOS Press. But at that time, when we published that, it was shared by the World Health Organization as the first evidence related to COVID-19, because people were homebound as well, and the ethical imperative of using telehealth during that moment. Other tools, well, the video that Penelope mentioned, I think is very important. Why? Because this video is not just academics talking about what needs to be done. This video was co-designed with several homebound people. They gave feedback, they evaluated, they provided images. We worked with a digital producer for months to create this video, and it has had a significant impact. Maybe in this link that you see here, it has been published in several places. So in some places have few visits, in other places have thousands of visits. Well, the website that Penelope mentioned, we have the report, the survey that Penelope presented. That's a community report. That wasn't peer review in the sense we published it for the community. Later, we did several peer review publications around that, but we published it for the community. So you can download the report. You can see all these pictures. All the pictures that are there in the report are, as I said, homebound people that share their emotions, their status, and also their recommendations for change. So you can visit this as well. So to advocate for knowledge translation and codify for impact. So if you are able to read any of our presentations, or sorry, to read out any of our publications, or if you have seen any of our publications, the core message, besides all the needs and what we have to do to support the homebound people, is that in order to create something that will solve these issues, we need to co-design the solutions. So we cannot work in a separate tower, only experts to think how telehealth will serve. For instance, it was very interesting, the microdoses, micro-treatment. So that's a fantastic idea. Then if we're going to implement micro-treatment, we have to work with homebound people, with ME people, so that they can tell us how this micro treatment should look like. Besides of course, the experts, the health experts, all sorts of experts. We need complex groups of expertise that can help us co-design any intervention, whether it's telehealth, etc., using the evidence that we already capture, but also producing new evidence that is specific to the populations that we are addressing at each time or moment. So in that sense, we created other publications, one in terms of the philosophy of person-centered care, why it needs to change, and we actually got some prizes for the most cited, the most download paper in terms of the trouble with personhood and person-centered care. We developed a way to measure the impact of our videos and other videos. We develop a methodology to co-design together and measure the impact of the changes that we create. So this is the paper in the middle. This paper has been very impactful, and it became a book chapter in terms of health service research. And we recently, developing all this work together, we developed a way to incorporate, on top of co-design, artificial intelligence, so that we can actually predict the probability of impact of any of these innovations and co-design them and tailor them as the system change with the people that is impacted by this any intervention. So these are, again, advocacy tools that you can use to say, well, we know what we need, we know how it needs to be done, and this is the evidence and the strategies that we can use to co-design solutions for us. So basically, this is a work that we have been doing for about 6 years now, and we keep publishing stuff. This is a recent summary that I did for Nature around experiences of care and what we need to do and why it's so important, and not only for homebound people, but also for First Nation people and other marginalized populations. So thank you very much. I'm sure Penelope will like to do a summary, a takeaway for our listeners, and then we're open for questions.
I think I've already said everything I want to say. The critical thing is that with the community and the researchers and the clinicians all working together, that we can create tools that we can then use, hopefully, to change the world a bit. That's the purpose. Yeah, thank you.
Right. Thank you so much for presenting. I again want to ask if there's any questions that people want to open with. Otherwise, I do have one ready for both of you, Penelope and Alejandra. All right. I'll start. We do have maybe about 7 minutes for questions, and then we'll present our next speaker. So I really enjoyed that you have really reinforced how significant advocacy and research are in this space. We can only do so much as clinicians or individuals, but people supporting the cause is really what advances and progresses things in this space. Do want to encourage everyone to access the resources that were shared in those presentations. And is there a way to share those QR codes in the chat, or where would people be directed to access them?
I think a really easy way is to make the slide deck available. When you make the recording available, if people can access the slides, then they can access the links, because the links work. If you click on them, if you've got them on your device, you can click on the link and it will work. And or you can use the QR codes.
I can print a PDF of the presentation so that you can, once you provide this link, this recording public, you can also upload the PDF there. People can download it and click on the links or use them as
Yes. Alejandra has to turn it into a PDF first so that when it's shared, people can't go messing around with it. But yeah, the links work, the QR codes work, so the slides are the source.
Perfect. Good. Thank you. And I also wanted to ask, you mentioned the importance of co-designing solutions for ME. I think often, things get a bit insulated in academic spaces and we forget the reason we're actually doing things, and it is for the people that are affected by these conditions. So how can people get a bit more involved in co-designing solutions for ME?
I'm involved in South Australia in running masterclasses on consumer and community involvement in research. It's a long answer. The big thing for those of us, whether we're clinicians or patients or carers in the community, is to reach out to either centres or individuals who are undertaking research and sort of go, yeah, I'm here and really keen to participate, not just in whatever you're doing, but in perhaps helping you work out what would be most useful for us, for you to do next. Because helping design the research question or bringing a problem, that's what I did with Alejandra. I said, here's this problem. Ricky has written a report. There's this problem here, and this problem needs fixing. And that's where all our work began, with that, just bringing the problem to the right place.
Yeah, so you can also connect with Health Translation SA if you are in South Australia. And I think in Queensland there are health translation institutes as well, or the Health Consumer Forum, or through active groups like we share. We have a Facebook group. Penelope leads many other groups. The EMI group has also contacts. So it's important to reach out to researchers and to these institutionalized bodies that help you to connect with researchers. Researchers need you as much as you need them. So, and there are different types of involvement, and there are different, we provide courses about how to engage with homebound people or how to engage with other populations. So it is fundamental to, get the right track and connection so that you get, we are happy, Penelope and I are happy to connect you and to help you to
Yes.
connect with the right groups. And we have many researchers, we have PhD students, they are interested in gaining touch with the community. And we have to institutionalize these pathways, and we have to find resources to support consumer engagement participation in health research.
Yeah. But I do think clinicians are the ones, when we do consumer and community involvement, the clinicians are often left out. So it's like, oh, you've got patients and their carers, and you've got researchers, and clinicians are they don't even get mentioned half the time. And yet clinicians are an important end user of the research. So it's absolutely critical that they are part of this community involvement in research. Yeah.
Thank you. Rachel had a question as well. If speech pathologists wish to do research, where is a good place to go? And I suppose related to what you've presented.
I would say that the health translation centres, of which there are at least 10 in Australia, there might be 12 or even 15 now. So they are funded by the NHMRC, and their role is to support research that can be translated quickly into practice. So I think the health translation centres, yes, Rachel's just said there's one in Queensland, there's one in every state. There's also one for women's health. There's 3 or 4 regional ones. So I would Google health translation centres
Yeah.
Australia, so you're getting the Australian health translation centres, and
Also, the Health Consumer Forum. The Health Consumer
yes,
Forum and the website, they always are activating calls for consumers to be engaged, to share their feedback in different areas. So those, they are not, they're like the health translation centers that they provide training, etc. But the Health Consumer Forum is a good space to connect to policymakers. And
except that it's the Consumer Health Forum. It's the other
yeah.
way around. CHF.
Oh, yeah, exactly. Consumer Health Forum.
Yeah. So, yeah, you can be on their mailing list and get opportunities to, from an advocacy point of view, really important to be part of their conversations, because otherwise, I mean, I've just been involved in the review of the Disability Discrimination Act, and some of the people are so privileged, and they really can't. They don't even have any sense of what it means to have such a complex and severe array of impairments. Severe ME is just beyond anything they can imagine. Greg's nodding his head. They're just, and unless you've got videos and quotes and can speak from your heart to these people, then we continue to be overlooked. So you can either head for your local translation research centre, or go to Health Consumers Forum and sit in roundtable conversations about different aspects of emerging health policy. Yeah, for sure.
Thank you so much. Thank you both, Alejandra and Penelope, for presenting this evening.